Okay,
That
so here we start. Good evening, everyone. We welcome you to NCSI Bulletin, that is Neurocritical Care Society of India's Journal Club. So here we try to bring latest significant article and try to dissect it, understand it, and know its significance in our practice. So this will be the first Journal Club article of year 2025. And today's article is about augmented renal clearance in patients of subarachnoid hemorrhage. So, as we know that subarachnoid hemorrhage is a systemic pathology, and renal system is one of the organs which is affected by several ways. Now, a compromised renal system is easily picked up by increasing creatinine level or falling urine output, but a enhanced or augmented renal function may be easily overlooked. So today we go through this interesting article which is published in Neurocritical Care Journal in November 2024 by authors from Department of Anesthesiology and Critical Care from Bordeaux Hospital, France. To present this article, we have two dynamic people with us, Dr. Swati Singh and Dr. Ashish Kumar Sahoo. So Dr. Swati Singh is Associate Consultant in Department of Neuroanesthesia and Neurocritical Care at Fortis Hospital in Noida. She has completed her SNAC PDF Fellowship in Neuroanesthesia last year at this institute. And later we will have Dr. Ashish Kumar Sahu, who is consultant and he is in charge of neurocritical care unit at Sir Gangaram Hospital at New Delhi. So he will throw his expert insights into this topic. So now I request Dr. Swati to kindly take over from here. So welcome Dr. Swati and Dr. Ashish.
Thank you, sir. Thanks for the
Thank you, sir.
introduction.
Thank you for the kind introduction.
Swati should begin.
So, good evening, everyone. Thank you for the introduction, sir, and Happy New Year. So, we'll be starting this journal article, which was published in the Neurocritical Care in November 2024 by Hughes et al., which is the augmented renal clearance, its prevalence, risk factors, and the underlying mechanisms in critically ill patients with SAH. So, to introduce what is augmented renal clearance, it's arbitrarily defined as a urinary creatinine clearance, which measures more than 130 ml per minute per body surface area. However, there are no clear guidelines that when do we describe it as augmented renal clearance. The importance is because it increases solute and urinary drug excretion. So, the dose adjustment of antibiotics and anti epileptic drugs using the daily monitoring of 24-hour urine creatinine clearance should be done. However, this is a time intensive and resource intensive strategy. Previous studies which have been done have been limited by either the small sample size or by the heterogeneous population included. So, this is a first study with respect to the SAH population. So we the pathophysiology of this mechanism is quite unknown. There have been some postulations that a combined inhibition of arteriolar vascular tone and increased renal blood flow in patients with greater physiological reserve is the major cause of an increased GFR and thus augmented renal clearance. There is some controversial role of increased mean arterial pressure or higher cardiac output. There have been some associations in the pathophysiology with regard to protein metabolism, sarcopenia, and renal hyperfiltration.
Oh, sorry.
The study hypothesized that a higher mean arterial pressure, a higher cardiac output, and greater urinary nitrogen loss would be associated with increased renal clearance in a specific population of patients with SAH. The primary objective of the study was to estimate the prevalence of and specific risk factors for augmented renal clearance in a homogeneous population of patients with SAH. And the secondary objectives included to determine the effects of mean arterial pressure, cardiac output, and the urinary nitrogen loss on the time course of creatinine clearance. The methods employed for this study was that it was a retrospective observational study, and this data was retrospectively collected over a 12-month period, that is from June 2018 to June 2019. This study was approved by the French Ethics Committee on Anesthesia and Resuscitation and required that all participants underwent at least one 24-hour urinary creatinine clearance measurement. They included all adult patients admitted with aneurysmal or non aneurysmal SAH to the neuro ICU of the Bordeaux Hospital in France, and they excluded post traumatic SAH and those with a history of chronic renal disease, as these patients did not show this augmented renal clearance. The prerequisites for this study was that the patient should be euvolemic, which was assessed by the daily cardiac ultrasonography, or if the patient was being monitored for the cardiac output using the transpulmonary thermodilution. The arterial pressure targets were individualized based on the clinical examination. They did TCDs, and in case there were invasive methods, to do the brain tissue oxygenation as well. If the cerebral vasospasm did occur, the mean arterial pressure was increased using an inotrope agent like milrinone, and balanced crystalloids were used for the hydration or when a fluid challenge was required for the process. Now, how did they measure the creatinine clearance calculation? They did the plasma and urine samples which were collected daily, and the urinary creatinine clearance was measured using this formula, which is 24-hour urinary volume, which was measured in milliliters per day, into the urinary creatinine level measured as millimoles per liter, divided by the plasma creatinine levels in micromoles per liter. This was converted to ml per minute and normalized to the body surface area using the Du Bois formula. The creatinine clearance was measured daily from entry to the ICU to day 14 or from neuro ICU discharge, whichever happened first. This augmented renal clearance was defined if the creatinine clearance rate was more than equal to 130 ml per minute per body surface area at any time during the neuro ICU stay. The data was collected using 24-hour urinary nitrogen loss served as a surrogate for the protein metabolism and was calculated as urinary urea in millimoles per liter into 0.056 divided by 2.14 plus for the non-urea nitrogen component 2 gram per day was included. The total mean arterial pressure and norepinephrine doses were collected hourly and averaged. The cardiac output values were recorded and averaged daily. They used invasive cardiac output monitoring using transpulmonary thermodilution. The other data, like the demographic and anthropometric data, the prognostic scores, aneurysms, and mortality status, and the length of neuro ICU stays were also included. Coming to the statistical analysis, mean plus minus standard deviations or as medians using the 25 to 75% interquartile range for the continuous variables was used, and for the categorical variables they used numbers measured in percentages. The data distribution was analyzed by the Kolmogorov-Smirnov test. The continuous variables were compared using the Wilcoxon paired sample test, and for the categorical variables they used either the chi-square test or the Fisher-Exact test. A mixed effects model was used to examine the effect of the mean arterial pressure. That is, they measure the mean of all the mean arterial pressures during the entire neuro ICU stay, cardiac output, and the urinary nitrogen losses on changes in creatinine clearance over time. The variables of importance were selected based on the Akaike information criteria. And being an exploratory study, no sample size calculation was possible, so they included all, that is almost 205 patients that we'll see, who were treated in their neuro ICU in that one calendar year from 2018 to 2019 June. So a total of 213 adult patients with SAH were eligible, out of which 205 were eventually included after removing those who did not give consent or those who had post-traumatic SAH. And they found that a total of 168 patients, that is a prevalence of 82%, with a 95% confidence interval of 76 to 87%, developed augmented renal clearance during their neuro ICU stay. Now, coming to the characteristics of the population and their significance. So they found that the first criteria that we can see, that is the age. So the clinical significance was that augmented renal clearance was seen more in the younger age group, that we can see 55 years compared to 63 years in the non-augmented renal clearance group. The sex predisposition did not have any clinical significance. With respect to BMI, they found that a lower BMI had a clinical significance in the presentation and the prevalence of augmented renal clearance. That is, the ones with lower one had a higher incidence of augmented renal clearance. That is a BMI of 24.6 compared to 27. With respect to the SAPS-2 score, which was used as a measure of the clinical severity of the patient, they found that the patients who showed a lower SAPS-2 score had more incidence of augmented renal clearance. With respect to the severity of the SAH using the WFNS score, Fisher score, they did not find any clinical significance with respect to the presentation of augmented renal clearance. Neither was there the presence of aneurysm, which was considered to be clinically significant for the prevalence in augmented renal clearance. Vasospasm occurrence was also not found to be clinically significant in patients with augmented renal clearance. However, they found that there was a slightly increased mortality in patients with non who presented with non augmented renal clearance. Now, comparing the covariates, they use the Akaiki information criterion, in which they found that when we add these variants, did the value that they get, was it less than the Akaiki information criteria value that they got? So when they did add age, they found yes, that it was clinically significant. History of high blood pressure was found to be an important covariate, as well as the mean arterial pressure during the ICU stay. The mean protein level during the ICU stay was also found to be an important covariate, and also the mean nitrogen loss during the ICU stay. However, the male sex, the mean norepinephrine dose, or even tobacco use were not found to be important covariates for this model. So, when we see the description of augmented renal clearance, they found that the prevalence was 82% with a 95% confidence interval varying from 76 to 87%. Now we can see that the 24-hour urinary measured creatinine clearance was used and graphed by using a smoothing function, and they found that there was a delay between the onset of SAH and the presentation with augmented renal clearance, which was found to be about a median of 4 days, with a confidence with a interquartile range of 3 to 6 days. The delay between neuro ICU admission and augmented renal clearance was found to be 3 days, median value with an interquartile range of 3 to 4 days. And the duration of ARC, presence of ARC, was found to be 5 days, with a median range of 2 to 8 days. And the duration, that is the percentage of hospitalization, was found to be 70%, 70 median days. Now we come to these graphs. They showed that a mean arterial pressure, which was measured using a median value with an interquartile range of 25 to 75, showed that the patients who had a higher mean arterial pressure showed a higher prevalence of augmented renal clearance. Coming to the second graph, with respect to age, using the interquartile ranges of 25 to 75, they showed that patients who came under the 25 quartile, that is, the younger age group, had a higher incidence of augmented renal clearance. The presence of high blood pressure before this showed that patients who did not have high blood pressure had a higher incidence of augmented renal clearance compared to those who did have high blood pressure before presentation. Compared to the urinary nitrogen losses, using the median values, they saw that those patients who lied in the higher quantile of 75 had a higher incidence of augmented renal clearance with respect to the urinary nitrogen loss. So the prevalence and risk factors of augmented renal clearance is poorly understood. The pathophysiology is still unclear, but they defined it as even one single measurement of creatinine clearance measuring more than equal to 130 ml per minute per body surface area during the neuro ICU stay, which was present in 82% of the population, compared to which was found to be slightly lower than the previously reported incidence of almost 100%. 95% with a confidence interval of 94 to 100%. The augmented renal clearance persisted for several days after neuro ICU admission, and the study strongly recommend that continuous 24-hour creatinine clearance monitoring should be done in all patients with SAH. The inhibition of arteriolar vascular tone, along with the increased renal blood flow of patients with greater physiological reserve, is accepted to be the principal cause of increased GFR and thus augmented renal clearance. And they found that older age, a history of hypertension, and a higher BMI were associated with absence of augmented renal clearance. So, higher mean arterial pressure contributes to augmented renal clearance in patients with SAH. There were some associations found with respect to the natriuretic pressures and hyponatremia in patients with brain injury with augmented renal clearance. Notably, cardiac output was not associated with temporal changes in the creatinine clearance in this study. So, macrocirculatory parameters like mean arterial pressure and cardiac output should not be seen as a cause of augmented renal clearance. Increased nitrogen loss was strongly associated with temporal changes, and augmented renal clearance may reduce the available doses of levetiracetam, vancomycin, or beta-lactam antibiotics. A slightly higher mortality rate was seen in the non-augmented renal clearance population. So we must carefully measure the renal drug clearance when choosing a particular drug regimen, and a validated method such as a 24-hour urinary creatinine clearance assessment should be used. So the inference was that a younger age, a history of hypertension, high mean arterial pressure during the neuro ICU stay, and greater protein and nitrogen loss affected the time course of creatinine clearance. The limitations of this study were that the major limitation was that it was a retrospective single center design. So we need prospective multi-center studies are required to further confirm this prevalence of augmented renal clearance in this homogeneous population. The available data did not allow us to adequately define the risk factors for augmented renal clearance, with a high risk of confounding found in patients with SA, such as a higher mean arterial pressure. 24-hour creatinine clearance overestimates the GFR, and a strong relationship was apparent between the urinary creatinine excretion and the muscle mass. GFR assessment, however, is limited by the lack of non-invasive bedside biomarkers, but creatinine clearance calculated using the 24-hour urinary output appears to be more accurate than calculated via the usual formulas, especially in specific populations. In addition, the urinary total nitrogen measurements were not obtained using the enzymatic urease method. So, the clinical significance of this study, the clinical implications of augmented renal clearance for patients with SCH must be clarified. Does it really affect the mortality or the neurological outcomes? And is there any possible effect of this process on the cerebral vasospasm or cerebral salt wasting syndrome should also be explored in further studies. So the study concluded that they recommend continuous 24-hour urinary creatinine clearance monitoring, at least in patients with SAH, receiving treatment with at risk for low dose regimen in case of augmented renal clearance, such as drugs like beta-lactams, low molecular weight heparin, or levetiracetam. And higher mean arterial pressure and increased nitrogen loss were associated with temporal creatinine clearance variations in patients with SAH. Thank you very much.
So nice
Over to Dr.
presentation, Dr.
Ashis.
Swati. Thank you so much.
Nice
So
presentation. Good work.
yes, so Ashish, would you like to throw some light on this topic more with
So,
regards to?
very good evening to everyone. This is well presented by Dr. Swati. So basically, this is a kind of study which dwells into the physiology of SH, where the SH is a hypercatabolic state, which leads to augmentation of blood pressure. Then there is sympathetic overstimulation is there, which leads to hyperperfusion of the kidney. So whenever the perfusion, generally, this study has found that when the mean arterial pressure increases, the thing is that the filtration fraction increases. So renally excreted drugs will be more effectively coming out of the kidney. So there is always a chances of theoretical chance of underdosing the patients. So what are the thing? And there is a and when the because of the SS, it is a hypercatabolic state. So it leads to increased nitrogen loss, which is a marker of hypermetabolism. Also, this also finds that this study didn't found any association with higher cardiac output, which is usually seen in the patient with SH. Did not lead to augmented renal functions. It might be due to the cardiac systemic function is overcome by the regional renal autoregulation that the study is not able to see. So what I feel that the problem with this study was the 24-hour urine collection. So in a resource setting, resource limited setting, it's very difficult to collect 24-hour urine. There are some alternatives like we can use a Cockcroft formula to estimate the GFR, which is a proxy estimate of your creatine clearance. But the problem with that is only for the stable this is only for the patient with stable creatine levels. It's not for the acute illness and not validated for acute illness. So still now the gold standard still remains the 24-hour urine collection calculating the creatine clearance. Though some biomarkers are available, but clinically they are not being used to calculate the creatine clearance. Like cystatin C is used nowadays. It is for the theoretical purposes. So another thing I would like to say, I think you will also say so what is the impact this thing happened was on the neurological recovery? Surprisingly, the patients with augmented renal functions were found to have a better mortality as compared to other patients. They could not find any change.
Less mortality.
Yeah,
Hmm.
but means the mortality was less. Obviously, the
Hmm.
patient they have found that the patient in which these are the young patients with the first time hypertensives who had a augmented renal functions, augmented renal clearance, as compared to patients who without ARC, who has a poor with the chronic diseases. So obviously, more sick patient will have a higher mortality as compared to the non patient with a lesser comorbidity. So, but theoretically, the thing is that if we do, there will be chances of underdosing leading to poor infection control, less chances of giving less heparin, and inadequate epileptic dose. So, what are the strategies which can balance the risk of ARC-related drug overdosing?
So,
For the important drugs, we can do a therapeutic drug monitoring in the patients who are supposed to have a ARC or augmented renal clearance is we are supposing drugs like vancomycin, beta lactams, and anti-epileptic laptops. There should be therapeutic drug monitoring should be done, and dose adjustment should be done accordingly. And the patient in which we are supposing there is a high chances of augmented renal clearance, doses slightly higher loading doses should be given in those patients, and we can develop specific protocols according to our own needs. And there are few studies which has done like so there are few supporting studies this has been done like they pointed out a few in this slide. Uday et al. They also found that prevalence was very high in critical ill patients, particularly in trauma patients who are supposed to have hyperdynamic circulations. Also, Hofstadter also found that there is increased MAP as a significant driver of renal hyperperfusion. Then Beretta also find that the protein metabolism and urinary nitrogen loss is a hypercatabolic state leading to the augmented renal functions. And Vincent et al. Also didn't find any role of cardiac output on the augmented renal clearance. This means that the renal autoregulation is more preserved within a variable cardiac output setup. And next slide. Yeah. Then also the other the studies. These are all heterogeneous populations. The study population is very less in these studies. This was the study. The present study is very. There's a number of population of the patients are high. And Robert et al. Highlighted a subtherapeutic level of beta lactams in ARC patients. So there is increased chances of treatment failure for renally excreted drug in ARC patients. So also Gordon et al. Find that the 24-hour urinary creatine clearance overestimates GFR because it doesn't take into account the creatine secreted by the renal tubules. So it usually 10 to 15% overestimates the creatine clearance. And more in the neuro patients because of the risk of because in neuro patients they usually have a hypercatabolic state or a sympathetic surge. So in that end, we will like that if if we are suspecting a young patient first time presented with SH without any known history of hypertension or kidney dysfunction, so there will be high chances of developing this ARC. And they found that this ARC usually starts after 4 days of SH, it does, and usually persists for 5 days after after the development of augmented renal functions. So, and this study they did it for till the patient, they collected the data till the patients were admitted or the patients were discharged or 14 days. Beyond 14 days, what happens usually is they have not been not very clear about it. So, Varun sir, how do you feel that is that something you usually see in your ICUs or everything? Do you change your medications doses according to this? Would you feel changing?
So nice. So this was a nice insight to us in our setup. So usually we don't look at the creatinine clearance, like as I mentioned at the starting, it is usually overlooked. So we don't really look into it unless the creatinine is increasing. We are always looking for whether the renal function is getting compromised. So this thing we have to keep in focus, especially with regards to if a patient of subarachnoid hemorrhage. We can see that if a patient has developed an infection, or if a patient has presented with seizures, and we are giving him, say, monoseph, uh, so we feel that the seizures are not subsiding. So before increasing the dose, which will be needed, we should know why the drug is not responding. And one of the reasons could be because the patient is having an augmented renal function, which we might have missed. So this will require overdosing or increasing the duration of giving the drug for a longer period of time. So this we should look into it. So both levetiracetam, all the anti-epileptics, they may be renally secreted. Antibiotics like vancomycin and beta-lactam antibiotics, they are frequently used by both neurologists and neurosurgeons and ourselves also to treat meningitis. So if a patient of subarachnoid hemorrhage, he has a EBD in C2, there are high chances that patient may develop meningitis. So we should look into it.
So
One thing, you can add to it, Ashish. Yes.
see, for these drugs like vancomycin or anti-epileptics, it is better to do a
Hmm.
therapeutic drug monitoring if we
Yes.
are
Yes.
planning to
Always.
increase the dose or change the doses. Because many a
Hmm.
times vancomycin is mostly excreted by kidney. And in this setup patients, usually what happens in neuro patients because of nephrotoxic potential, what they do is they usually underdose the vancomycin in most of the
Underdose.
setups.
Yes.
Usually
Hmm.
because of the risk of developing AKI or everything, and ultimately it leads to progression of the infection leading to longer hospital stay. So it should be suspected in a young patient. Definitely, you should suspect any neurological patient that is coming to you, not only in SH, also it can be extrapolated to other conditions also. For a patient in which there is a
Correct.
hypercatabolic state you
Hmm.
are suspecting.
Hmm. So, one thing about is, how do you feel about creatinine as a marker of GFR estimation? What do you suggest are the major limitations of using creatinine, 24 hours creatinine?
So as I was
Ashish, Swati.
previously, uh,
Hmm.
Swati, you want to add or should I? Swati should tell something like that.
Hmm.
So creatinine, because there are other, basically the muscle catabolism also has some role. So just creatinine clearance will not give us a very good estimate of the total, as a correct measure of the renal hyperfiltration. There are other mechanisms like that inulin clearance and all that we can use. That will be give us a better idea of the actual GFR, which we are not able to use because of the resource limitations.
Mm. Yeah, so creatinine
So,
clearance, creatinine is a very poor marker in patient who has a poor muscle mass, those who are frail patients if they have some liver problems. So it is not a good marker. So using a 24 creatinine clearance, although this is the most preferred method still in USA, I was going through the literature. Before renal transplant, they prefer a 24-hour creatinine clearance as their marker for a patient to be a donor for uh, renal transplant. But it has its own side effects. And as you mentioned, inulin and DTPA, they are a better inert marker because they are not reabsorbed by the loop of Henle. So they are a better inert marker of measuring GFR. So anything you would
speaking
like to add, Ashish?
even I would like to add to is the problem with the
Mm,
only thing, the creatinine is a breakdown product of the basically muscles. It's also secreted by
mm,
muscle, and also the renal tubules also excrete creatinine, which leads to overestimation of GFR. Problem with this that even if we use other step, only that is 24-hour urine creatinine is the actually way in which the most of the studies has been conducted on creatinine clearance, because there is no other way to do it in a large scale of population. If you go for radio like inulin and DTPA radioisotope, it's a very experimental kind of thing. It's very difficult to do in most of the patients. It's usually done in very selected kind of patient in which you wish to see whether the functioning of the kidneys is a functional stance. So it is difficult to do. Still now the gold standard is 24 hours creatinine clearance. Although we can use a GFR, estimated GFR we can use, but it is usually estimated GFR by Cockcroft formula where you use the plasma creatinine as a plasma creatinine or serum creatinine, you take serum creatinine. Is not recommended for the studies or in actual clinical practice. Dosing based on that.
okay. So, Ashish, are you using any bedside point of care monitor for assessing creatine clearance at your institute?
No, no, we are not using it. Is although some institutes it is there. I have seen. I have not seen also. It is a point there, but nowadays there are point of care creatinine which continuously measures the urine and gives you the creatinine clearance is available. But I have not seen it. I have not seen it here also. Most of the places I have worked, I have not seen it.
Okay, so I think we are near the conclusion. So, just as a closing remark, Swati, you are the younger one. So, what what did you gain from this study, and what would you like to bring in your practice? How can we improve our practice? Would you like to add
Uh,
something to it?
yes. So basically, I think when we, especially in the ICU setup, when we see neurocritical care patients, we often think about this acute kidney injury. So we are most of the time we are decreasing the dosing and doing the renal dose modifications. However, this parameter, that is augmented renal clearance, was quite an eye opener. That yes, that means there are certain drugs, especially these renally excreted drugs that we are using quite commonly, levetiracetam, enoxaparin, beta lactams, which are and especially vancomycin with respect to meningitis, we're using so commonly, and we don't even measure whether the patient. Of course, sometimes patient improves, but this parameter we can use to see if there has been a drug failure, the patient has had a repeat seizure episode. We never thought that. We just think that he did not take the medicines. We never thought that okay, his the pathophysiology of his disease mechanism of this renal cause can also give rise to drug resistance, number one, number two, therapeutic failure. And at least if we are not able to use a 24-hour urine creatinine clearance, I think we can estimate using the Cockcroft galt, or we can use some other methods maybe in our clinical practice to further help our patients prevent these kind of failures to happen, and ultimately improve in the patient outcome. So it's a new thing that I read thanks to this journal,
Good.
and I think we
Mm,
should include it in our daily practice, at least in some populations, especially where we are suspecting that okay, the antibiotic is not having an effect, or there has been a seizure recurrence, or sometimes even with enoxaparin we see that the patient still has a stroke or something. Maybe it could be because of this phenomenon that we have not studied.
okay. Uh, and Ashish,
Yeah,
your take, your last few words,
it is.
like
Swati has summed it
in.
very well. So
Mm,
only thing is that for any young patients with less than 40 years who comes to ICU with a suspicion of SH or any clinical neurological disease, at least we should. I feel that at least 5 6 days down the ictus, we should at least do estimate the creatinine clearance once. At least if we have a very strong suspicion, and we should not underdose the patient, because I have seen patients in which the Clexane was started after SH coiling because of stent assisted coiling. Clexane was started, but dose was reduced because of risk of thinking that it may cause bleeding and everything. Ultimately led to blockage of stent and development of new infarcts. This is very clinical, but because of the nobody is thinking about the pathophysiology that is happening behind the disease. So at least at least once we should check
Okay.
it and see whether it is causing any problem or not.
Okay. Okay. So I thank Dr. Swati and Dr. Ashish for their insightful contribution today. And on behalf of NCSI, we thank our viewers for watching this podcast. We also request you to subscribe to our NCSI channel so as you continue to receive updates about our upcoming podcast and get access to our previous feeds. So once again, thank you everyone. Good night.
Thank you.
Thank
Thank
you.
you. It's a pleasure.
Good night.
Thank you. Good night.